have your attention, please? A very good afternoon to all of you. This is going to be an informal learning session to sensitize all of you on genomics testing, and give you an orientation on the importance of genomics and what to do and what not to do, and how to do it, and how best to do it. And this is not going to be a one-day event. It's going to be a series that comes in sessions from today onwards. So I will save all of your numbers, those who have registered. If you have not registered, I take your numbers. I will create a group for genomics testing, and I will be giving you study notes, sharing you study notes to just to learn what is genomics. Slowly, slowly we'll infuse the learning curve so that we become experts over a period of time. We accumulate all the certificates that are issued to you, and I hope I will be able to convert all these participation certificates into a diploma certificate towards the end when the credit hours are met. So that is my target. So please take this very seriously, and then keep your certificates that you are getting from now onwards. Okay. And my name is Dr. Balaji Subramanian. I am the principal of the School of Biomedical Sciences here at Balaji, Vidyapeeth. If you guys are not aware of what is School of Biomedical Sciences, it's a new endeavor, a constituent unit of Balaji Vidyapeeth, started last year. And we conduct BSc, honors and MSc programs in biomedical sciences. Okay. And the school adopts STEM-based education, integrating medicine. STEM, science, technology, engineering, and mathematics. All these four concepts are integrated into the learning of medical sciences. So it's a different curriculum. And with that little note, without any delay, I think we will get started because it's going to be a tight program. We have with us Professor Aranivel. We have with us Dr. Aranivel who will be speaking, and we have Dr. Aruna Sharma, Principal IGHS, who will be speaking. We have with us Dr. Karthikeyan, Pediatrics, who will be speaking. We have Professor Ashok Kumar Das, who will be speaking. Each of us will be taking 10 to 15 minutes to highlight their specialties. And in addition to these clinical experts, I will be introducing to you the fundamentals of what is a gene and so on. And then we have Dr. Bennett Vasco Das, who is the CEO of the Genomics, 30M Genomics Private Limited. We have an MOU with a company to provide genomic testing here at Balaji. Okay. So anything you want to know about genomic testing and how to use it in your clinical practice, the facility is open. It is located on the second floor. The facility was inaugurated by the Chancellor, and it is a full service facility for clinical care. And in addition to that, we also do training programs and education. So if you want to get educated and trained or doubts cleared, you are most welcome to come to the second floor or send me a WhatsApp to the same number that you sent a WhatsApp to me. Okay, that number will be open 24/7, 365 for you to ask any questions related to this field, and we'll be able to answer. Okay, so with that number with me, no formality, so I'm free and open to all of you. With that little note, we'll get started. And I was asked by quite a few people, sir, can you tell us what is the basic of gene, genome, what is the genetics, what is genome, what is DNA, what is mutation? And then, and there was a reason why I called this program a refresher program. All of you would have read all these in the years backwards, but I thought I'll give you a touch upon that knowledge and refresh your fundamentals. If you know well what we are going to talk about in the next few minutes, it's enough. Otherwise, sit back, relax, and enjoy. Don't worry about catching all the points and then engraving it into your brain. Okay, we'll learn slowly. Then I will be sharing with all of you study material. Okay, so that you can save, and slowly you can study. see, I want you to, this slide set, all of you will get this slide set, and all my lectures will have a number. Okay, starting with L1, and I'm giving you a number to refer to, just in case you have any doubts or you want a notes about it. I'll be able to share with you and work with you. This is nothing but 2024-0409. That is how the number will be coded to refer to. Okay, and many of you, when I talked to, they raised a lot of apprehension about genomics. They said, that's not my cup of tea. I don't know what is genomics, why I should do that. I have my own clinical practice. I'm better off than genomics in practice. And my point is, if you raise such apprehensions and stay inside, locked inside your apprehensions, so you should come out of it. You should come out of these apprehensions and embrace genomics. I'll tell you why. Very seriously, I'm telling you why. So this is the truth. Where have we come from? We were in medical era and we still continue to be in medical era. You know what is medical. I don't have to define you what is medical. You all know medical. And anything that is related to medicine. I also teach medical terminologies. Most of you must know. If you don't know, I will tell you. If you take the word medical, it has two parts in it. Medic and al. Al means related to. So anything that ends with al means related to. So this is anything related to medicine is a medical era. And we all were in that medical era. Then from then on, we moved on to the genetic era, where chromosomes were talked about, genetic testing was talked about, and there was confusion, there were limitations, and from there now the science has moved to genomic. Okay. So what is genetics and what is genomics? This confusion exists. Genetics is gene related. This is again another word. ICS, two words, genet, ICS. ICS means study of. Okay. Anything related to gene, study of anything related to gene is genetics. Anything related to genome is genomics. Very simple. Okay. So that raises a question, what is genome? We'll come to that. And this is the ladder, okay, under which the science developed. We talked about genes. From genes, the chromosomes. We are moving to the higher body. Gene to chromosome to genome. Okay. And then genetics looks at single gene. Genome looks at the entire environment. Gene plus its environment. I tell you a new concept in healthcare these days. Dr. Panival and I were talking the other day. It is the environment that matters in healthcare hereafter, not necessarily the body physiology and pathology. It is the environment in total. And in addition to that, the upcoming trend is environment plus time. Okay, Genomics. Genomics is the future. So single genes versus interaction of genes with the environment is genomics. It's a bigger picture. I'd like to quote Dr. Parthasarathy, Professor Anesthesiology. In his lecture, he quoted one which I liked very much. He said, genome is a whole book. The chapters are chromosomes, 23 chapters. And the sentences in each chapter is 18. Fantastic. Very, very simple way of putting it. Okay. So we have moved from sentences in a chapter to chapters to the whole book. So what is the scope of genomics testing is, these are the different areas. The experts that are going to talk now followed by me are going to emphasize on these specific areas. Believe me, this is a first eye-opener session. Okay, don't expect to learn everything at once. Slowly we'll teach you, we'll train you. Now, what is genetic material? That's the fundamental place where we start. What is a genetic material? Genetic material refers to anything that is hereditary. And there are two things you might have heard about DNA and RNA. What is the genetic material? It is the DNA that is genetic material. Okay. Not the RNA, at least in humans, not the RNA. RNA can be a genetic material in viruses. Okay. But as far as humans are concerned, it is the DNA that is called the genetic material, necessary to pass on the information to generations. Okay, so that is where our focus lies on. And there are good differences between the DNA and RNA. DNA, as you can see from the picture here, demonstrated. RNA is equal to it. Okay, and there are bases. We'll go to that in the next slide. Okay. There are bases. These are the fundamental units of your DNA. There is a base. There is a sugar. Okay. These two forms a nucleoside. When a phosphate group adds to it, it becomes a nucleotide. Okay. This is a fundamental unit of DNA. Now, where do we get this base from? There are 4 bases. We'll see what those 4 bases are. You have read already. These bases are derived from amino acids in the body, biochemistry, metabolism. Okay, amino acids are converted to bases in the body. And then sugar is added to it. What sugar? There is a pentose sugar. Pentose means 5 carbon atoms. Pentose sugar is added. But the difference between DNA and RNA is in DNA you have deoxyribose sugar. Ribose is 5 carbon atoms. Okay. In DNA, deoxyribonucleic acid, DNA. Okay. Otherwise, ribose is there. It is ribonucleic acid, RNA. Okay, that's the basic difference between the two. Now, there are 4 bases. We saw bases, sugar, and phosphorus. Okay, phosphate group. There are 4 bases in DNA. We call it ATGC. Adenine, thymine, guanine, and cytosine. These are the bases. These bases are derived from, as I said earlier, derived from amino acids. And amino acids you get from food, or body recycles itself. The cells are recycling, and sources are derived from there as well. Okay, recycling plus from food. Amino acids, 2 bases. Bases with sugar, with phosphate, nucleoside becomes nucleotide, and then they all come together. They form base pairs. These are the base pairs. 2 strands of DNA, and there are bases on this DNA, and there are bases on this DNA. They pair and they form base pairs. So this is one terminology you will frequently come upon, base pairs. Okay. In DNA, thymine is there. In RNA, thymine is knocked out and it is uracil. That is another basic difference. Now, this is a very important slide. Okay. This is a very important slide. Look at it. I will share with you. Look at it. You take this cell here. Take the human body, you take the tissue, you go to the cell, and you go into the cell. You have this nuclear material, nucleus, and the nuclear material. Then the chromosomes. This is the order of splitting it. Chromosome, it's a mesh of strings. Okay. Chromosome is a mesh of strings in a sequence. So you pull out the chromosomes, and then it comes out as a single strand, like a string. To pull that out, the string is made up of DNA, okay, and then proteins. These DNA and proteins. Proteins are histones. They are special proteins. They are called histones found in the nucleus. And then the proteins and the sequence of these DNA, they form the nucleosomes. Somes means body, in the nucleus. They are in the nucleus, nucleosomes. Okay. Now, if you split the proteins from the nucleosomes, then take only the genetic material, and then you stretch it out, and then try to understand it. It is a sequence of genes stacked one over the other. Okay. And then if you take those genes and then split them to understand what it is nothing but these base pairs in 2 strands. Okay, understood? You can stop me if you have any doubt. Now this is the sequence that you see in a DNA. 2 strands, bases, they pair up, base pairs. Normally this is how it should be. ATGC in several combinations they are there. Okay, these ATGC combinations. In these sequences, if there is a mistake, okay, if there is a mistake in the right sequence of ATGC, it is called a genomic variation. This is where our interest starts. Okay. If there is a genomic variation in the number ATGC, not right, if there is something typo error, okay, and the system, cellular system types, when there is an error, it results in genomic variation. Single nucleotide variation is 1. One letter is replaced by mistake by another letter, not the correct sequence. Then it is called a single nucleotide variation. Okay. You all are aware of, heard about SNPs. Then single nucleotide variations, SNPs. What is SNP? What is SNP? Both are same, but there is difference between the two. Single nucleotide variation is, you can see that in somatic and germline cells. Okay. Whereas SNPs are present only in germlines with clinical importance. And it should be at least seen in 1% of the population. So on that definition, SNP is SNP. Yes or no? SNP is SNP. But if it is in the germline only and is prevalent in 1% of the population at least, then it is called SNP, single nucleotide polymorphism. And see, all SNPs, when identified, they are given this number. If you go to literature and if you see, there is a number like this. Okay, that RS1291382. Somebody discovers that there is an SNP in a patient, in a sample given. It is reported. When it is reported and submitted, it goes into the database. It's a global database. Random sequence identification number is that. That is what RS means. Random sequence identification number. Okay, so each SNP has a number. So don't get bogged down by, what is this number and all. Something complex. It's very simple. So each SNP is identified by a number. Now SNP, SNP are single nucleotide variations. And that is seen here, SNP. One letter gets interchanged or not known. Okay, like here. If a sequence is inserted in, that does not belong there, but it is inserted, then it is an insertion. This is also a genetic variation. If it is inserted, it is genetic variation. If a sequence is deleted from the normal, it is not a variation. Tandem repeats. A sequence is repeatedly put in. I tell you one hot information that came out 2 days back. 50% of, this is the latest scientific publication, 50% of human diseases, 50 human diseases, not 50 human diseases, they have generated direct evidence with tandem repeats. the more understanding, the more testing is taken up, we can have a better understanding of the disease pattern and how to handle it. So these are the common ones you will be facing as we go from. Now those are related to those letters. Okay, delete one letter, delete 2 or 3 letters, insert them, delete them, repeat them. All of those happens. What if there is a in toto shift in the sequence that gives a structural variation? You look at the chromosomal level. Okay, if there is a big change, the chunk is shifted. Okay, like tectonic plates shifts, it creates structural variation. Again, deletion. As you can see from the picture, it doesn't need any explanation. A big portion of the chromosome is deleted, duplicated, inverted, inserted, or transferred. Each one manifests in one form or other in the clinical scenario. Okay, got it? So where does the genomic technology come in? All those variations and the manifestations can be analyzed and understood if we embrace the genetic technology. We will not talk about the genomic technology now, but just know that genomic technology is there. There are different methods of doing it. We will do that in another lecture. These methods of analysis are employed, and then we will be able to give a personalized conclusion, interpretation, and patient care, because we are going to take the patient's DNA, analyze, and accordingly give him the care. It's much more personalized. This is where genetic testing differs big way from genomic testing. Okay, genetic testing will be based purely on symptoms. Even if you do a genetic testing and then start a treatment, you'll be only treating the symptoms, not the cause. Genomic testing can be giving a treatment for addressing the cause of the disease. Okay, big difference. And this can be used in understanding the disease or diagnosis or prevention or treatment or diagnosis. Wide. And with that I will stop. And this is my WhatsApp number, not my WhatsApp number. There is a WhatsApp number of the School of Biomedical Sciences. If you are not registered, please send a WhatsApp your name and affiliation. I will include it in the database. Create a WhatsApp group. I will be sharing, without any program announcement, I will be sharing notes to you, some short notes for you to refer to understand. No exams will be conducted. Just understand and develop efficiency to embrace the technology in the future. Okay? Thank you very much. On behalf of all of you, on behalf of James Harry, the Dean, Director of Hospital Services, I welcome our Vice Chancellor. He's been a strong supporter and a visionary on this genomic testing. These 4 iconic figures here, Vice Chancellor, Dr. Ashok Kumar Das, Sitesh, and Dr. Kumar. These 4 were iconic in materializing this concept, and we pitched in to help and get this moving. So with their support, Professor Niranjan Biswas is here to motivate us to get up to speed. And I request you, sir, to continue.
Good afternoon. So, you are having lunch. Now, Not hungry, huh? And Dr. Bala, you have taken me 4.5 decades before. I was listening a lecture. I thought I am in a biochemistry class. Yeah, exactly 45 years ago when I was in MBBS. And this, I used to read that Harper's biochemistry of this structure of DNA, RNA, nucleotide. Thymine is replaced by uracil, so it is RNA. Excellent. Okay, okay. So, dignitaries who are present here, ladies and gentlemen, students, we have assembled here today to witness starting of a new facility. That means adding one more feather in our cap, in the cap of Sri Balaji Vidyapeeth. And as I was told that there will be a crash course on genomic testing. Is it going on today or it will be? There will be more. It starts today. So that is the theory part. And now onward, diagnostic services also will be available at our genomic testing facility. And that is, I think, in the second floor of medical college. You see, usually what happens, this type of test usually done in the private lab, and clinicians they get it done from them just on payment basis. In very few places in medical colleges this facility is available. Even I inquired from AIMS New Delhi, they don't have this facility because they told the patients and the investment is not cost effective. So better get it done from, say, what is that lab? Lab, Lalpa, yeah, that is the best lab. But good that we are starting it here with Bala's initiative and all of your support. And you know, whatever you told, it's very interesting. Translocation, translation, and all other, how this happens, this genetic disease. And you know that DNA structure, double helical structure, the DNA of thing happens after that, and that changes the whole scenario, medical diseases, diagnosis and treatment. But still, whatever we have understood, that is the piece of the iceberg. Still, maximum is undiscovered. The diseases, genetic diseases, whose pathology is yet to discover. But with new technology, with AI and other advanced technology, slowly, many genetic disorders which we come across in our routine patient in the OPD in all branches, medicine, nephrology, neurology, any other branches, pulmonary medicine. So we are getting so many patients with this new technology, so we can find the solutions, diagnosis as well as treatment. Or at least if you know the cause, we can provide counseling services. If you think that this is uncurable, that will be a burden to the parents, at least we can tell medical termination of pregnancy or whatever the counselor says. So this is a very urgent, important, and must do of the medical treatment and diagnosis section. Another thing is in traditional medicine or traditional treatment, what we see when randomly Dr. Das is here, he is prescribing medicine. So maybe 1/3 patients get benefit because we are not doing the genetic testing before that, the genome. 1/3 maybe not responding to the treatment, and rest 1/3 probably so many side effects, serious side effects, compliance is not there, patient don't continue the treatment. So precisely we get 33 to 40% patients get curable diseases. But nowadays with this precision medicine or personalized medicine, before prescription, if by biomarkers diagnostics or by utilizing this genome testing facility, if we can find out that what dose will be sufficient for this patient or which drugs will be better for this patient, so that is called personalized medicine. So that will benefit 100% of the patients. So that's a great boon to the patient community by utilizing this genomic testing facility. So I hope that after attending this class course, who are attending, the attendee, they will learn the fundamentals of this gene and genomics. The basic thing you should know first, and then their applicability or their applied part, particularly the association of the disease and its possible treatment. So in that way, this course is very much needed and important. And in our genetic testing facility, there will be all 3-in-1, preventive, clinical, and the wellness genomics. All three will be available in one place. So you are helping us from Hyderabad. So in nutshell, I congratulate the School of Biomedical Science, particularly Professor Balaji, for setting up this genomic testing facility in collaboration with our MGM Advanced Research Institute. And I wish so many clinicians are here, senior residents, junior residents, who are here, the PG, will be benefited immensely, particularly decision making. Who should be treated? When should be treated? How should be treated? Who should be tested? And not only the patients, it's congenital disease, patients' siblings, patients' parents, that's important. And I see in my own contact, sometimes it happens that patient is suffering, and when you get inquiry, and then the patient's mother is also having the similar disease, say cervical carcinoma and other things. So unfortunately, so that means there is some link between that. Particularly to diagnosis the congenital diseases. So thank you very much, Bala, for inviting me to preside over this CME and sharing my ideas. Thank you very much.
Thank you very much, sir. With your blessings and motivation and support, we'll march ahead with all the people who have gathered here. Now I request Professor A.K. Das to.
Esteemed Vice Chancellor, our Director of Hospitals, and our esteemed Dean, I will be very brief. I have been given 10 minutes. Now, the purpose of this meeting, as Rishi and Dr. Bala Nehru has pointed out, is to sensitize where we should do this genetic testing, and we have people amidst us who are going to tell us the ways and means to do the testing. And they have been here last 3 or 4 occasions what type of tests we are doing and how it can be useful for our patients. I must first of all emphasize the fact that genetics medicine is one of the branches of medicine which goes to every specialty. Today, genetics has developed as a very important branch of medicine, and both clinical genetics and basic genetics are very important. We have DM program in genetic medicine. We have somebody in Pondicherry whom I have also spoken to. She will be coming here. She is Rina Negi sir. Rina, she will be coming here from the Department of Pediatrics, JIPMER, and she is DM in genetics. She will coming here. So what's my purpose here? In 10 minutes, I'll give you 10 examples. I'm not a geneticist. I'm basically a clinician, but I'll give you example the areas on which I have worked in genetics in collaboration. We grow in collaboration, and having worked, what I have got out of it. Number one, dear friends, you know I am interested in diabetes. I'll show you first how we have utilized this test for the diagnosis, for the prediction and prevention of type 1 diabetes. This project was started by the Department of Karolinska by one Dr. C.B. Sanjeevi, who is the next door. He is in Chennai. And what we did, you know, type 1 diabetes is a immunogenetic disease. That means you must have the genetics makeup for developing type 1 diabetes, DR4, DR2, whatever you call it. At the same time, you must have the antigens which will produce this disease. Having only the genetics not enough. It's a immunogenetics you must have. So we have got so many antigens like anti-GAD antibody, anti-zinc transporter, and extra ICA antibody against the cells of the pancreas. So if you have a genetic makeup and if you have this autoantigens, they produce autoantibodies and they will destroy the pancreas. The project we did was to predict. There are few families which are very rich, and they had one sibling in their family who had type 1 diabetes. They wanted to know whether we can prevent the type 1 diabetes in the other sibling. They were not twins, other sibling. So what we did, we tried to find out the genetics and found that they had the same genetic makeup as the person, as the index case who has got type 1 diabetes. The challenge was the parents were interested how we can prevent type 1 diabetes coming to the other sibling. So the answer was to see that they do not get those autoantibodies against the ICA, IA, insulin autoantibody. They should not get the antibodies against the pancreatic cells, zinc transporter 8 autoantibody. So what we did, that we tried to recruit them in a trial, which was a global trial of modulation of the immunity, and this was the modulation by giving a very costly drug and very powerful drug called cyclosporine. So we found out this family's relatives stay in Canada where this trial was being done. So this child, actually their own brother, so they went to Canada, they recruited in that particular trial, and they were giving the cyclosporine drugs to change the autoimmunity, and this type 1 diabetes could be prevented for a certain age. So one can predict type 1 diabetes by knowing the genetics. If the genetics is there can be type 1 diabetes, but it will not manifest unless you have this autoantibodies. You know, doing GAD antibody, doing IA has become very common today. So to predict type 1 diabetes, this is very important, and to prevent also is very important. If you give this immunosuppressive drugs, you may prevent development of type 1 diabetes. In fact, there are so many studies in the world today where people are trying to prevent type 1 diabetes by finding out first the genetics. You must have the basis genetics to have type 1 diabetes. Even if you have hundreds of autoantibody, one will not develop type 1 diabetes unless the basic genetics is there. So that is very important. The second study I was involved was very, very interesting. It was one of the IAS officers in Pondicherry, and you know him, he is also related to me. He was called Dr. Sahadev Sahu. His wife had developed diabetes and very severe peripheral neuropathy. And one of my colleagues, he gave gabapentin, I gave usually pregabalin for neuropathy. He gave gabapentin, and lo and behold, in 2 days, he developed multiple eruptions over the lip, on the tongue, inside the mouth, then over the body. What was it? It was SJS, Steven Johnson. Gabapentin, day in and day out, it does not occur in everybody. It occurs in the people who have a particular gene which is found 1 in 16,000. Because he was a local senior administrative officer, we could get the test done, and we found that his wife was given, it was given by, you know, many of you know him, Ram Niranjan Sahu. I'm just telling the names because he is Tumanathan's batch. And I would have given myself, it's not because that he gave. We also, gabapentin will give very high dose for the temporal lobe epilepsy. And that was the, what Professor Biswas, our esteemed Vice Chancellor, mentioned. It was the immunogenetics, immunology, the genetic of the particular patient who carried the side effect of this drug. And this can be avoided by what he was speaking, which is called precision medicine or personal medicine. So we found that it was a Steven Johnson syndrome because this Mrs. of the IAS officer had a particular gene through which he was susceptible to develop SJS, and she developed SJS. Of course, lo and behold, we could make a change in the management also. Third example I'll give is the example of, sir is not here. You know, I'll tell him I have not taken his permission. Professor A.K. Antakrishnan is very intolerant to metformin. Some time back, he never had hyperglycemia. So, not me. Somebody had prescribed him metformin. You know how much weight he lost? I think he lost to 27 kg weight loss. He could not eat anything. So I must tell you that it is because of the fact there are some people, because of genetic makeup, they're intolerant to metformin, which is today #1 drug for treating type 2 diabetes. And that is called precision medicine. And we have not done genetic testing for him, but I'm quite certain this metformin intolerance was because of genetic makeup. And you know, this can be only found out by looking at the OCT1, organic cation transporter gene 1, organic cation transporter gene 2, which we have done with one of my PG, Dr. Praveen, who is in States today. And we have not done for him. I'm giving an example that metformin, even though the largest used drug in type 2 diabetes, one can find out one is susceptible to develop complications or one will tolerate metformin by looking at the genetics. So that is what is called precision medicine or personal medicine. We have not done this, but I will give you an example that a very common drug you can find out the toxicity. The next example I will give is very, very important. Of course, there is also a publication from our institute, but the case I'm alluding to is somebody whom we saw in some other hospital. It was a child aged 4 months and he developed very severe diabetes. You know, when the diabetes occurs in infant, the common practice is to give insulin, and the child was given insulin. And you know, the control was there, but not full control. The dictum, there are some dictums in medicine that if type 1, if the diabetes developed before 6 months of medicine in the infant, it may not be type 1. So neonatal diabetes is usually non-insulin requiring diabetes. And this child was tested and it was found that the patient had that particular gene, KX, fifth gene X, and this particular child had PNDS, that is permanent neonatal diabetes, and the treatment was not insulin. The treatment was sulfonylurea. And till today, this child is on sulfonylurea and child is doing extremely well. So this is, I think, Capital here. You are going to speak about it also. You have got the publication from here. This we had published from elsewhere along with Mohan. So it is very important, and you can only diagnose neonatal diabetes if you do the genetic makeup. So please remember, infantile diabetes below 6 months of age, almost certainly either PNDM, permanent neonatal, or transient NDM. It can be diagnosed only by TMP gene. And the treatment is sulfonylurea, and the parents were so happy that the freedom from insulin and sulfonylurea. I've got 3 or 4 examples, sir. 2 minutes more. The second example was there is a fellowship from the DBT, Department of Biotechnology, and I had applied for the fellowship. You need a preceptor who will accept you. So Sanjeev was my classmate. I wrote to him. He said, you apply, I'll support your application. So he supported my application, and we were both posted in the Karolinska. That's how I went to that famous Nobel Prize Institute where I could see the Nobel Prize award ceremony. And you know, there, this work was done, finding out the maturity onset diabetes in the arm. Now, if you have a diabetes which gets transmitted in 3 generations, grandfather, father, and the son, is a vertical 3-generation transmission. If it occurring below 25 years of age, it may not be type 1, it may not be type 2. We call it maturity onset diabetes, and this is totally different diabetes. The beauty is that we have till today identified 17 genes which are responsible for Modi. We also had a work with whom, sir, can I say this about you, sir? I am sometimes amazed by the zeal and the love for MGMC or a particular person, Nirmalji. And he brought French, big round of applause for him. He brought the French delegation, he brought the Romanian delegation yesterday. And you know, this French delegation was visiting us that time when this case was seen. There was a Philippe Frogel, a French gentleman who had diagnosed GCK gene. And this patient, one particular patient, was typically not type 1, type 2, but it was Modi diabetes. These Modi diabetes, even though after very young, do not need insulin. Many of them need only sulfonylurea, and the beauty is 90% of them do not get any complications. So you know how beautiful it is. So Modi is a type of diabetes which can occur in the families, which can occur in the very young age when they do not have type 1 diabetes or type 2. They're in between or Modi. They need sulfonylurea, and they're very mild form of diabetes except HRF1, which can be little serious. They do not get complications. The last example I'll give, you know that some people say that I smoke and I have not got any complications. Now, I do not see a smoker patient. That's my personal take on that. So I do not encourage smoking. But you know, there are many smokers who smoke like a chimney, chula, but they do not get any complication. Why they don't get any complications? It is because of genetic makeup. Similarly, in diabetes, there are some people whose sugars H1C above 10, they do not get any complication. There are some people H1C 7.1, 7.2, they develop what we call museum of complications. So what is the difference between the two? The difference is in the genetics. It is proven today that, you know, I'll just give an example. I think my friend is here, ophthalmology, in Indian patients get less diabetic retinopathy. The reason is that they have particular type of gene where retinopathy is much less, DR4. So I think anybody is here from ophthalmology? So this is a very known fact. Retinopathy is genetic. It's good news for us. Good news that we do not have retinopathy so much in our country. That is because genetic. You go abroad, you will find 30% retinopathy. Here it is much less. Maximum, sometimes 10 to 11%. I discussed with Dr. What is his name? Arvind Eye Hospital, the people who started it, Dr. Durai Swami, I forgot his name. Venkateswamy. He said it is much less here because of the makeup of the genetics. Similarly, we have the kidney complications, which clusters around one particular family and gene. There is a cross-link also. If we have, in our study, we have shown that diabetic nephropathy occurs in clusters. If they do not have diabetic nephropathy in the family, they will have hypertension in the family. That's called cross-clustering. Am I clear? Diabetic nephropathy families cluster, occur together. If they don't have nephropathy, they can have hypertension. So hypertension families and nephropathy families can cluster together. So that's one way of finding out. Somebody said there is also a particular gene called ACE gene, 5 ACE, the drug you give, ACI, that is all the pills, lisinopril, ACE inhibitor. So the ACE gene is found in the kidneys. They are also found in the heart. And therefore, there is a link between nephropathy and cardiopathy. You find the type 2 diabetics or hypertensive who develop nephropathy do not die of ESRD, they die of heart attacks because we say nephropathy is fertile soil on which heart attacks occur. There is a link between the ACE inhibitor. The last thing before I leave, I must tell you that genetics is that branch of medicine which pervades everywhere. I'll just give one example of cancer, colorectal cancer. One particular genetics, if you give aspirin, it is prevented and the colorectal cancer gets much modified. If this gene is missing, it will not be modified. Now in cancer, which has become very important, sir, all the MDs today don't want to take up endocrine. They want to take up oncology because oncology has become very important. And the entire cancer treatment is centered around genetics today. Whatever, BCA gene for breast cancer, BRAF, the entire oncology is centered around genetics. I'll end by saying cardiology. Anybody here? Parthiban, Prem, Giri, we have a joke about them. They did work on genetics for 20 years. In 20 years, they found one gene. Which gene is that? Gene for the HOCM, hypertrophic obstructive cardiomyopathy. But having found the gene, it is fabulous. We have many patients in Pondicherry. We have done the genetics, found out the HOCM gene. We do not allow them very heavy exercise because this HOCM die of sudden cardiac arrest. Dear friends, I'll stop here, and I just wanted to give the example of the diseases where I was tell you very friendly more. Thank you very much.
Thank you very much, sir. That was very useful and motivating. And following you, I would be requesting Professor Karthikeyan to come and a mention was made about Watson and Crick. Vice Chancellor mentioned about Watson and Crick. I had the privilege in my life to sit with Watson, had a cup of coffee, and I was with him for about an hour chatting about the DNA discovery. And for many of you, those who don't know what Watson is, though he discovered DNA, he had a controversial character. He attributes the distinction in DNA to racism. So he has that controversy. Professor Karthikeyan.
Good afternoon all. For the next few minutes, I will be talking about the genomic testing in pediatrics. As sir has already told, genetics is a study of genes and their roles in inheritance, just dealing with the heredity. But genomics is studying individual genes. Genomics will be studying all the person's entire set of genes. For diagnosing a genetic disease, we have three major elements. That is, first one is a detailed medical family history, then followed by a physical examination. Then only comes our clinical and laboratory testing, that includes our genetic testing also. For a genetic disease to be suspected among the children or anyone, we need to have some red flags. This automatically becomes the indications for genetic testing. There is occurrence of a condition among the family members, multiple miscarriages, stillbirths or childhood deaths that is occurring more than one family member, family history of a common adult condition, then developmental delay, mental retardation, congenital abnormalities, dysmorphologies, unusual physical features as well as growth problems. But there is one important indication that if a clinician is suspecting a genetic disease, that becomes automatically an indication for doing a genetic testing. And number two is, if the parents suspect that their child has to undergo for a genomic testing, then also we have to do a genetic testing. So uses are like newborn screening, carrier testing, perinatal diagnosis, diagnostic or prognostic, and predictive or predispositional. Newborn screening, at present we are restricting ourselves to the biochemical testing alone. We are not extending the newborn screening test to the extent of genetic testing, because we follow something called Wilson and Jagner criteria to include a particular disorder into the panel of the newborn screening. The first and foremost, it should be a very common disorder and it should have a serious impact on the child's health. Number three is, at least there should be some form of treatment available for these disorders to be included into the newborn screening panel. So at present we are restricting ourselves to only the biochemical testing for including the disorders into newborn screening, but there are some countries who include genetic testing also for newborn screening. Carrier testing is something like before the couple become planning for pregnancy, they will undergo a carrier testing in which they are at risk of passing their children. They are at risk of passing the genetic mutation to their children. So it is an allele, okay, which is in a recessive condition. Examples are cystic fibrosis, sickle cell anemia, or Tay-Sachs disease. It is offered to individuals who have a family history of a genetic disorder or people in ethnic groups with an increased risk of a specific genetic condition. So the main important thing we have to remember is both parents are to be tested. The prenatal diagnosis is when the mother becomes pregnant, then we offer this prenatal diagnosis. Is used to detect the changes in the fetus genes or in the chromosomes. It is offered to couples with an increased risk of having a baby with a genetic or chromosomal disorder, because I have already told that multiple miscarriages, the previous baby is suffering with a genetic disorder, or previous baby is suspected to have a genetic disorder. The tissue sample for testing can be obtained through amniocentesis or chorionic villus sampling. Chorionic villus sampling is usually done between 11 to 13 weeks and amniocentesis is between 18 to 20 weeks. But the criteria is like it should be done as early as possible. 11 to 13 weeks, we should not wait for 13 weeks. Offer the testing as early as possible at 11 weeks itself, starting of the 11 weeks itself, so that you get the reports and then you decide for further continuation of pregnancy. So diagnostic or prognosis, you confirm the diagnosis when there is a symptoms. After the symptoms have occurred in the child or in the newborn, then you offer the genetic testing, or it is used to monitor the prognosis of a disease or the response of a treatment. It can be in any part or it can be all together. Predictive or predispositional, when you identify the individuals at risk for genetic disease and you offer them and you tell them that they are at a risk of developing a genetic disease. Particularly useful it has been if it is a family history of a specific disease, or an intervention is available to prevent the onset of the disease or minimize the disease severity, like the examples are carcinomas or early onset coronary artery disease. All these things, early onset diabetes, all these things comes under predictive or predispositional screening. So it has extended its arms into every field of medicine, in pediatrics and medical genetics, fetal and neonatal medicine, microbiology, infectious disease, medical oncology, all the areas genetics have entered. So what are the applications? analysis and characterization of the genes abnormalities leading to the disease, understanding the disease pathogenesis, we can understand the disease pathogenesis, and we can detect the gene mutation. With that we can predict the offspring transfer, and also genetic disease of the patterns of inheritance can be studied, and also diagnosis and screening of the genetic diseases for the other family members, offer a prenatal diagnosis, and also identification of disease carrier states, and also pre-marriage counseling can be offered. The types of genetic testing offered is a cytogenetic and your molecular. Cytogenetic is nothing but literally called as chromosomal, where you screen for either numerical problems or structural problems. Numerical problems collectively called as aneuploidy screening, and structural problem, as sir has already told, either translocation or deletion, insertion, all these things. Molecular is going for a next generation sequence. So these are the internet sources which are valuable for us. A person who is ordering for genetic testing also should know how to use that and how to interpret that. For that we have so many databases available. An Indian genetic database, it's still in evolving phase. Many mutations have to get into it, and we can search from through these areas. We can search, and then we can collect the data. Okay, then you go into the Indian genetic database. Then you search by either disease category or a disease name or the gene name. With that we can get all the statistics with the relevant information we can obtain from this website. So there are ethical, legal and social issues in genomics. So we should understand all these things, then only we can get into the testing. It definitely improves the outcome. Genetic testing definitely improves the outcome in the forms of it can redirect to a palliative care or a referral to a patient to an appropriate center where the intervention is available, or a possible change in the parent's future reproductive decisions, and also the implementation of the treatments. What are the key points to be remembered? Take a detailed medical and family history. This is the first and foremost important aspect in genetics. Number one, the bedside testing which can be done in genetics is the 3-generation pedigree charting. Okay, that's a very important one. 3-generation pedigree charting is the important bedside test that can be done, which gives a lots of information. And don't forget about the consanguinity and early infant death. Proper application of the testing strategies for establishing the diagnosis. While testing, you should also know the limitations of that particular testing, and also how to interpret the test and how to go about with the counseling, because genetic testing is not just ordering the testing, it involves counseling, pre-testing counseling, while testing counseling, and also after obtaining the reports, counseling is always needed. Thank you.
Thank you very much, sir. That was very crisp. May I request Professor Aruna Sharma to principal of IGIDS. There is a scope beyond medical to dental as well, so she's here to highlight and enrich your knowledge. By the time she takes up the stage, another latest information today available is based on the 2024 Apollo Health report. India is declared the cancer capital of the world. So when you guys come into a complete medical practice and take over, you will be facing all these genomic testing into your practice. So enrich yourself, please.
Honorable Vice Chancellor, Professor Nihar Ranjan Biswas, sir, respected Dean of Academics, Professor Ashok Kumar Das, sir, respected Director, Hospital and Outreach Services, Professor Nirmal Kumar, sir, respected Director, C-Dreams, Professor Abhishankar, sir, respected Dean, Professor MGMCR, Professor Sitesh Ghosh, sir, other dignitaries, my dear friends, students, and colleagues. It's all in the genes. I think this is an adage which all of us are familiar with. something in the genes. Actually, if we think about this, this really gives us something to ponder about, something for us to think about. So, once I say it's all in the genes, it's in the genes, the first thing what we think about is this double helical structure of DNA. And believe me, your susceptibility to diseases, whether it is oral diseases or diseases in any other part of the body, is also regulated, or it is modified by your genetic makeup. So if I say, if the question of the day, does your DNA determine your risk of dental issues? Yes, the answer goes without saying. So if we see, diseases are generally classified as single gene defects, chromosomal aberrations, just as Sir discussed about the transversion, translocation and all, and multifactorial. Once we say multifactorial, it means many factors, including the environmental factors as well as the genetic factors, which are going to play a role. And most of our oral diseases are multifactorial in nature. Just a small peep into the numbers. There are about 3 billion nucleotides in our DNA, in our 23 pairs of chromosomes. So, and we are 99.9% similar. That means 99.9% of the genetic makeup of the individuals is similar. The difference is what we observe among the individuals can be accounted for by that 0.1% of the variation. And if I look into the numbers, that 0.1% of 3 billion stands at about 3 million. So if you remember what Dr. Bal Nehru sir was speaking, there are about 3 million polymorphisms or changes in the gene, changes in the DNA, in the sequence of the nucleotides of the DNA. And this is what is accounting for discernible differences among the individuals, including the susceptibility to disease. So coming to most of the common oral conditions, which we all know, early childhood caries, that is a form of dental caries, which occurs in children less than 6 years of age. Then we have the dental caries, which is occurring in elderly populations. The gum disease, or otherwise referred to as gingivitis or the periodontitis, oral cancers and the premalignant conditions, malocclusions or irregular alignment of teeth, and orofacial clefts. All these do have a genetic background. Now, dental caries, well, it is considered to be one of the most common conditions affecting the mankind. I would say it's the most common because the manifestations of dental caries last the lifetime of the individual. All of us suffer with common cold, but the manifestations do not last. You're cured of it. You may get another episode of common cold, but dental caries is not so. A restored tooth, a filled tooth, is always a filled tooth. The tissue which is lost forever. So hence, the manifestations of dental caries will last the lifetime of the individual. And this uncontrolled dental caries is actually, if you say, is highly dysfunctional, but rarely fatal. Because it is not fatal, it does not even get the attention what it deserves. The patient will not report to you until and unless there is severe pain. But by the time the pain occurs, the process has already involved the underlying pulpal tissue. So it would require more invasive treatments. And caries in primary dentition or your milk teeth is a predictor of caries in permanent dentition, and the accuracy is to an extent of about 100%. So if you see caries in a child less than 6 years of age in his primary teeth, then the occurrence of caries in permanent teeth is for sure. So, coming to the basics, it is of genetic basis of disease. The rationale is one allele of a gene seen more frequently in subjects with the disease than in subjects without the disease? This is one of the most common rationales what we use for genetic testing. And when I'm talking about dental caries, the literature has shown that 4 groups of genes, I'm not saying 4 genes, but rather 4 groups of genes have been implicated in increasing the susceptibility to caries. They are the enamel formation genes, that is the genes which control the development of the dental enamel, or the most hardest tissue of the body, which is the one which is covering your teeth, visible into your oral cavity. The next one is the immune response genes, because immune response depends upon the interaction between the human genome as well as the host microbiome. The third one is your genes which control the salivary composition and flow. And the fourth one, the genes which control your glucose metabolism and which actually say you have a sweet tooth. So any variations in any of these genes can actually increase the susceptibility to dental caries. If we see the susceptibility with respect to periodontal disease, again, we have different groups of genes, especially those genes which play a part in inflammatory and anti-inflammatory cytokines, immunoreceptor gene polymorphisms, antibody gene polymorphisms, and certain enzymes which actually regulate the destruction of the connective tissue of the body. This is what is going to result in periodontal diseases. Malocclusions. We all know that the dental formation or the tooth formation is under precise genetic control. It all happens with cell signaling, migration of cells from the initial stages of a notochord to form the ectomesenchyme, and from the ectomesenchyme we have the development of the dental tissues. So any changes in any one of these pathways will actually result in changes which are discernible as irregular alignment of teeth or malformation of the teeth or the jaws. Oral cancer and potentially malignant disorders. As Sir had just stated, some of them who smoke like a chimney seldom suffer from cancer. But some of them who may just get exposed to passive smoking may develop cancer at a very early stage. All this differences, again, is attributable to genes. And now, literature has shown us that there are many genes which are involved in oral cancer, both those in stage 1 as well as in stage 2. Those in green color are generally associated with stage 1, and those in the blue color associated with stage 2. Clefting. Formation of oral tissues, as I've said, is under genetic control. So wherever there's a failure of epidermal tissue dissolution, where the connective tissue fails to grow to eliminate the cleft in between, is what is going to cause your cleft lip and cleft palate. And many genes such as MSX, fibroblast growth factor, all these homeobox genes, group of homeobox genes, all these genes are involved in the clefting of the orofacial region. So now, coming to basic diagnostic tests. Currently, we have certain staining techniques, certain cytological techniques which help us to discern between the normal cells and the cancer cells. But with a lot of technology, we do have something called as studies which help us in understanding the DNA methylation. Methylation, that means where a methyl group, a CH3 group, is added onto the DNA. That is what actually causes an alteration in the susceptibility to a condition. So you have tests to understand the DNA methylation profile, and then you also have the mRNA, that is your messenger RNA biomarkers, and of course the protein biomarkers. And the other developing technologies which will involve in the testing facility include your AI, that is your artificial intelligence, and lab on chip. This is something very, very interesting, wherein you will be able to test many, many polymorphisms on a single chip. The chip will be almost the size of your SIM card. With that, you will be able to test for an array of diseases. Well, all this, we think that genetic testing is very, very expensive. But rather, contrary to this notion, I would say that the sequencing cost is actually plummeting down. It is coming down and down and down. It is becoming more affordable for the common man. And I think this is the time when we will have to exploit it so that we can give the best to our patients. Coming to the diagnostics market, which was about 7.2 billion in the year 2017, has gone up to 12.5 in the year 2024, and it will continue to increase. This is mainly attributed to an increase in the technology, especially your genetic testings. Now, this is actually an era of multi-omics or multiple omics. You all must have been aware of the term genomics. That means any changes in your DNA, gene. That is your genomics. And you all know that the RNA is synthesized from the DNA. And the RNA is what transcribes the message from the DNA into the cell. So any changes in the RNA is what is called as transcriptomics. So the study of changes in the RNA related to one particular metabolic process is what is called as transcriptomics. And you all know the mRNA carries the message from the nucleus into the cytoplasm, resulting in the synthesis of the protein. So any change in the RNA, which is because getting reflected due to a change in the DNA, will cause a change in the protein. And any study of changes in the protein thus produced is what constitutes your proteomics. And any change in the protein will affect the metabolism. And that is what is called as metabolomics. And an understanding of all this multiple omics is very, very important if we have to move closer to something called as precision medicine or precision dentistry. Because we all know that no one size fits all. Each individual is different. Each one has his own unique identity. And each one of us will not respond in the same way to the same treatment. So understanding the basic genetic makeup is very, very important. And in fact, we also have something called as gene therapy, which is actually where you will alter the gene. You will remove the defective gene to replace it with the proper nucleotide. That is what is called as CRISPR-Cas9 system, and that is what has been awarded the Nobel Prize in the year 2022. So applications, host of applications. The first one, the genotype. Once you understand the genotype, you can try to relate it to the phenotype or your characteristics of interest. It will help you to understand the biomarkers, which are the basic etiology of a disease, for the risk prediction, and then for the prevention of the disease, for your targeted treatment. So once you identify a genetic makeup, a genetic difference, you're going to target that individual, that particular pathway, to bring about the necessary changes. Your pharmacogenomics, that is how you will respond to a particular medicine. As I've told you, all of us will not respond to the same treatment in the same fashion. There's a change. And of course, your nutrigenomics. All these becomes the application of your genetic testing facility. And to conclude, I would like to say that every trait, whether physiological or pathological, has a genetic basis. And it is left up to us as clinicians to understand this so that we can deliver the best services to our patients. Thank you.
Thank you, madam, and it was very interesting to hear from the dentist perspective. And gentlemen have to leave for other administrative assignment. So we'll continue. Now Dr. Bennett Vasco Das, who is the CEO of the 30M Genomics Private Limited, is here to talk to you about with whom we have signed up an MOU to provide the genetic testing services here at Shri Balaji Vidyapeeth. And he is a MTech PhD, and he did his PhD in genomics in Jupmer, and he is highly qualified to talk about the future of genomics here at SBB. Basically, he will be the front end for you regarding the service, testing service.
So, thank you so much. Very good evening to all. Before I speak about precision medicine or personalized medicine or genomic testing, Professor has covered almost whatever I thought to talk. So, we started this genomic testing, genetic testing, whatever we can call it, majorly as an assistant, just like a nursing assistant, as a diagnostic or a prognostic assistant for the clinicians. So that's our primary motive. So we will be, how a normal diagnostic test, a pathological or a microbiological test will give you a result that will assist the clinicians to get onto a treatment or decide a treatment. So similar to that, more precise and more specific is the molecular testing or the genetic or genomic testing. So that will give more inputs compared to even a pathological biochemical test and all. So with this particular genetic data, you can create a more precision decision on the medical treatment. So that's the primary motive here. When we say precision medicine, it can be even considered as personalized medicine. And when we take this precision medicine as a whole, it can be preventive. Okay, so normal precision medicine, it can be preventive. It can be used for treatment decisions. It can be for lifestyle decisions, and it can be for improving the quality of life. I will get into each. I'll give you an example also. When it comes to precision medicine under preventive, so Professor has said about HCM, hypertrophic cardiomyopathy. So I have some slides for that also. So this is one of the genetic disease which can be diagnosed, I will not say diagnosed, prognosed very, very early, and it is preventable. So this is one of the disease, just one of the disease with which just with a genetic testing we can find out and we can prevent it. So similarly, familial hypercholesterolemia. So that can also be predicted or prognosed with the help of genetic testing. Similar to that, in each department there are several diseases are there which can be prevented just with a genetic testing. Just with just a small genetic testing, we can prevent it. Rather than getting the disease, diagnosing it and going for some treatment, when you predict a disease, you have enough time to make lot of decisions compared to just with a diagnosis and going off with a treatment. And second thing is the treatment. Sir said about metformin. So FDA has approved almost 300 drugs under pharmacogenetics. So in where this genetic makeup of the patient changes the response to the drugs. So these 300 drugs falls under different category. It includes antiviral drugs, Abcavir. Abcavir is one of the drug which response depends on the genetic makeup of the patient. So apart from the cardio-related drugs, diabetic-related drugs, psychiatric-related drugs, so many drugs, almost 300 drugs are approved by FDA. There are several researches going on. Still, when FDA is approved, it has lot of data. So FDA has approved 300. And whatever testing we are doing here comes under this FDA. We are doing only FDA approved drugs. We are not doing anything only based on the research. And you might have heard about black box warning in drugs which is sold in US. black box warning. So some of the drugs like clopidogrel, warfarin have this black box warning. For example, clopidogrel, if it has to be prescribed to a patient, the warning on the bottle itself, the drug bottle itself has a warning that the patient has to be genotyped or he has to undergo a genetic testing for 2 SNPs. In CYP2C19 gene, he have to undergo genetic testing for those 2 SNPs. If the genetic testing report is not there, it is not recommended to provide the drug to that particular patient, especially for clopidogrel. Because clopidogrel have a lot of side effects, and most of the people clopidogrel don't work. So that they can go for the alternate drug. So you can decide on the treatment just based on a genetic test. And next is the lifestyle. Sorry, it was not that clearly. Lifestyle. So when it comes to lifestyle, sir, said about HCM. HCM's another name, common name is, it's called athlete silent killer. So most of the athletes had this problem, HCM, and many people died because of this sudden cardiac arrest due to HCM. It's called as, it's a nickname itself, it's athlete silent killer. So we can find out that with the genetic testing. And you can see most of the people who is like involved in this gym activities or athletics, they will be having the problem of hair loss. So this hair loss also have a genetic background called androgenetic alopecia, male pattern baldness, female pattern baldness. So these also can be predicted with the genetic testing, plus the drugs used in this hair loss, especially minoxidil and finasteride. Both are the 2 drugs approved by FDA for hair loss. Those are the only 2 drugs approved by FDA for hair loss. Minoxidil and finasteride response is based on the genetic makeup of the patient. Almost 60% of Indian people don't respond to minoxidil. Still, minoxidil is the highly prescribed medicine for hair loss. 60% people don't respond to it. And once they start taking the medicine, when they will come to know that they are not going to respond is after 6 months of usage. They have to use for 6 months, then only they will come to know that they are not going to respond. Similar thing happens with finasteride. Of course, finasteride is used in very low dosage in hair loss, so the side effects is less. But the response to finasteride depends on the genetic makeup of the patient. So that's one thing. Next, cosmetics related, which is like growing industry in genetic testing, cosmetic genetics. So anti-aging drugs, anti-inflammatory, all these drugs based on the patient's genetic makeup. So if they do a genetic test, they can find out which kind of cosmetics they can take. All this related to lifestyle and the quality of life. When it comes to quality of life, the drug side effects. If a patient is taking a drug, the side effect of the drug should be minimal or it should be 0. So the quality of life of the patients will be improved. Yes. So where we can apply this precision medicine? So as we are talking, we can apply this precision medicine in almost all the departments of medicine, starting from oncology. As sir was rightly mentioning, oncology is the hot topic in genomic testing right now, because pharmaceutical companies are developing drugs. They are developing drugs which is corresponding to particular mutations. Example, KRAS mutation. In lung carcinoma, KRAS mutation. They are developing drugs which will work in patients who is having this particular mutation. So before going for the treatment, they have to undergo this KRAS mutation testing so that they will find out and take that particular drug. They need not to go for any other drug. So similarly, it can be even applied to prenatal testing. Sir was talking about prenatal testing, finding out this Down syndrome and other chromosomal abnormalities. So the same thing we are doing with the NIPT, non-invasive prenatal testing, where we even need not to go for amniotic fluid or CVS sampling. We will just collect the mother's blood. When they are in the first trimester of pregnancy or 3rd month or 4th month of pregnancy, we will just collect the mother's blood, because fetus DNA will be circulating in mother's blood for a short time. So what we will do, we will collect the mother's blood, and from the mother's blood, we will take the fetus DNA, which is very, very minimal amount that it is fragmented. We will take that fetal DNA and we will find out whether the baby, the fetus, is going to get any diseases or not. It's not limited to genetic diseases. It's not at all limited to genetic diseases. Now genomics has gone far beyond. It's not only about genetic diseases, non-communicable diseases, the risk of getting cardiovascular problems, the risk of getting diabetes, the risk of getting cancer. I will give a very good example. We all know about the famous Hollywood actress Angelina Jolie. So Angelina Jolie is the best example for genetic testing. So what happened is her grandmother had cancer. Her mother had cancer. Both of them died because of cancer. So Angelina Jolie had a doubt whether she will also get the cancer or not, and she underwent genetic testing. They checked for BRCA1, BRCA2, which is related to breast cancer, and they found that she have more risk to get cancer. And she underwent surgery and she prevented herself from cancer. So this happened almost 10 years back. So that's the benefit of this genetic testing. And cardiology, as I mentioned, HCM, familial hypercholesterolemia, all can be prevented, and the drugs related to cardiology also can be precisely given based on genetic testing. So apart from that, psychiatric drugs. So this is one major important area we have to look into, because most of the psychiatric patients, they don't know how to express the side effects of the medicine. Most of the times they will skip the medicine. Even the clinicians will struggle a lot in treating psychiatric patients. So genetic test will help how the patient will really respond to a particular drug. Even if the patient is having any side effect, the patient will not be able to tell that. But this genetic testing will be helpful to find out that. And endocrinology, skincare, so I have covered this. Right? So I'll just get into this hypertrophic cardiomyopathy. So as sir was mentioned, this hypertrophic cardiomyopathy had a very, very important connection with South Indian people, especially South Indian people, altogether South Asian people. Why it is there is a particular mutation which was found in 2009 by CCMB Hyderabad, a particular mutation in a gene called MYBPC3. So this is a 25 base pair deletion in this gene, and this particular deletion is more common in South Asian people, more common in South Indians. And this particular deletion leads to hypertrophic cardiomyopathy. And if a person in a family have this deletion and other people in the family have 50% chances to get that deletion. There is almost 20 years of evidence is available connecting hypertrophic cardiomyopathy with genetic mutation, this MYBPC3 and MYH7 gene mutation, and also sudden cardiac arrest. And if your patient or if your person undergoes this genetic testing and find out if he has the chances to get HCM, and if he is below 25 years of age, there is lot of chances to prevent this HCM in that particular patient.
Can I stop? Can I stop you for a minute?
Yeah.
We are providing this service here at SBV. This.
Yes. So this is the athlete silent killer. This is also very helpful if a person wants to go for a gym. Okay, because if the person is having this particular mutation, it's not at all recommended to do heavy exercises. Even there are few cases, I hope you might be heard of Kannada actor Puneet Rajkumar, who suddenly collapsed in gym. So this sudden collapse in gym while doing exercises is becoming more common nowadays. And recently in Bangalore, a 45-year-old cyclist, he is a cyclist for 20 years. So he suddenly collapsed. 2 months back, Tata conducted a marathon. At the end of marathon, 2 people died because of sudden cardiac arrest. So we are not very sure whether this HCM or this particular mutation is the reason or not. But before getting into such kind of heavy exercises or marathon and all, if you undergo this testing and knowing about your health is very, very important to prevent you from these kind of incidents. And as I mentioned, this particular mutation is more common here in India, right? So South Asians are more prevalent to this particular mutations. Yes. So apart from this is about preventing the disease. Apart from this, personalized medicine or the precision medicine or a drug which is suited for a single person, which is designed for a single person. So we can give lot of examples starting from metformin, clopidogrel, statins, lot of examples are there to say this. Okay, so same medicine, same dosage won't fit for all, right? So this is another one application for that. And what kind of samples are required for this genetic testing? Usually for a commercial genetic testing, for a preventive genetic testing or pharmacogenetics in which we will find out the drug dosage and all, mostly we will not go for invasive sample collection. We will just take the saliva sample. Just a saliva sample is sufficient to find out most of the genetic problems and the genetic associations, and that's the most commonly collected biological sample for genetic testing. And next to saliva is the blood sample, and we will also collect tissue samples, especially in cancer biopsies. We will collect tissue samples because tumor DNA behaves differently compared to a normal DNA. So to find out that, we will collect tissue biopsy to be more precise. And for prenatal testing, we are collecting two different type of samples. If it is non-invasive prenatal screening, if it is screening, we will collect maternal blood, and when it comes to diagnostics, we will collect the amniotic fluid or the CVS. Yes. So how these genetic tests are done? There are many different technologies are available to do this genetic test, and the basic and more economical is the conventional PCR method. Every technology has its own limitations, and every technology has its own cost also. When it comes to conventional PCR methods, you can do almost 70% of the genetic test can be done with a normal PCR test itself. So apart from that, we can go for real-time PCR test, and most precise or most like gold standard is the sequencing methods. And again, sequencing is of two types. One is Sanger sequencing. Sanger sequencing is like if you want to sequence a very short sequence of your DNA or very targeted mutation you want to find out, you will go for Sanger sequencing. And if you want to find out some new mutations or whole genome sequencing, if you want to understand a patient's whole genetic makeup, then we will go for NGS. Apart from that, karyotyping, fragment analysis, many almost 50 different technologies are available to do genetic testing. Based on the requirement, based on the particular disease, and based on the particular drug, or based on the requirement of the clinician and the patient, we will fix the technology. So how usually we will do is, we will collect the sample, either a saliva sample or a blood sample, then we will extract the DNA from that sample using different methods we have. We will just extract the DNA, then we will subject it to PCR method or sequencing method to find out the mutations. So once we find out the mutation, then comes the main picture. So finding the mutation is just up to the experimental part. Once we find out the mutation is the main picture, where you have to find out the importance of that particular mutation. Because in case of genetic testing, most of the people, almost 95% people have a doubt that whether the data is really trustable or not. That's the main problem. Because when it comes to Indian population, we don't have that much genetic data available. Very little genetic data is available. Now only government started doing lot of genomic projects. We have very little genetic data. So there is a question of trustability in the genetic results. So after doing this mutation analysis, that's what we will be doing. So what we will do is, we will get the data from multiple regions, not only from India, the population related to Indian population, the diseases related to that particular disease, a very big data analysis we will be doing, and we will be finding out the association of that particular drug or the particular disease with the particular genetic mutation. So this is the bioinformatics part we will be doing to find out the precise information about that particular mutation. Because finding the mutation is not the big part, connecting it with the disease is the important thing. So this is the basic format of your requisition form for use for taking the genetic test. So you can see here, the major thing we will be requiring is patient's medical history, family history. Without these two, we cannot perform any kind of genetic test. Family history and medical history is very, very important. So when we are doing these two, it's only called as genetic test. So we are taking it one step ahead. We are collecting the lifestyle related data also. Whether the person is a smoker or a non-smoker, whether he have the habit of taking alcohol or not. So what kind of lifestyle habits he is having, what kind of drugs he is taking, other drugs not related to that particular disease, so other kind of drugs whatever he is taking. So what kind of job he is into. So all those lifestyle related information also we will take into the picture so that we can give you a precise data on the result. So this is an example of a genetic report. So you can see here, so this is especially made for precision medicine report for clopidogrel and statin. So this is one of the top requirement for most of the cardiologists, clopidogrel and statin, because when a person comes into cardiology department itself, the first and foremost drug nowadays they are giving is the clopidogrel, and 75 mg is the standard dosage they are giving. But if that particular patient is having this mutation of STAR2 and STAR3, even just one mutation, CYP2C9 in the CYP2C19 gene, just one mutation, he cannot take clopidogrel at all. He cannot give. We cannot give prescribed clopidogrel to that particular patient. If we prescribe clopidogrel to that particular patient, side effects of that drug will start occurring, which is bleeding. So it is not at all recommended to give even 75 mg. And if the patient is undergoing any PCA interventions, PCA or ACS, it's not at all recommended to give clopidogrel at all if that patient is having the mutation, even 75 mg or whatever. Okay, because usually for ACS and PCA patient they will go for 150 mg, even higher dosage of 600 mg also they will be giving. So in that case it is very, very critical. Similarly statin, the most commonly given statin is rosuvastatin. Most commonly given is rosuvastatin, and rosuvastatin also have problem in some particular patients where we cannot prescribe rosuvastatin. Instead of rosuvastatin we have to go for other low intensity or medium intensity statins. So that is very important. So you can see here in the same report itself we will be giving three things. One is the genotypic report, what the kind of genotype he is having, so what dosage and what drug you have to give. If you already prescribed clopidogrel to the patient, how much risk he will be getting, the percentage of risk for the side effects, the percentage of drug response by the particular patient. In percentage we will be giving it. So you can make a very precise decision on the drug prescription. And second thing, drug-drug interactions. So when we are giving clopidogrel, clopidogrel is a drug which will interact with the rosuvastatin. So this drug-drug interaction, rosuvastatin will interact with the aspirin. So this drug-drug interactions we will be giving in the report. Next, drug-disease interaction. If a particular drug is given, what are the type of diseases can happen, or with what diseases it will interact. So that information will be given. Plus the lifestyle interactions. For example, I will give a very small example. There are studies available in which they have found, this is a very surprising result actually. They have found that smoking increases the response to clopidogrel. Whoever smokes, they have more response to clopidogrel. Smoking is connected with cardiovascular diseases, but smoking increases response to clopidogrel. So in case of smokers, clopidogrel will work very good. So these kind of informations also we will be giving. And in case of atorvastatin, if your patient is prescribed with atorvastatin, the patient should not take grapefruit juice. Grapefruit juice should not be given, right? So these are some of the examples. So same thing we have given for trichology. So I'll stop with that.
Thank you very much. This is the last part of the session. I requested Dr. Panivel to speak at the end because he's going to give you a consolidated overview, the clinical perspective, a very important session. I request all of you to be there.
Yeah, very good evening. I'm sure that thank you for many opportunity for this last batsman. I'm sure many of you are in the verge of leaving. So my point today is here, I think as a teaching university, our scope for genomic testing will be wide. So what you have projected is more the pharmacogenomics. But as a teaching university, let me show you that why we at all, a clinician needs genomics in clinical medicine and what is the scope from my discipline. So I am here not as a subject of genomics expert, but as a lay clinician who is always on the lookout for a precise diagnostic test and treatment for my patient. Why I mean very precise diagnostic test and treatment is because the contemporary clinical medicine, most of the diseases are diagnosed as a common homogeneous. We have a standard symptoms and signs, and you label a diagnosis and you give a treatment. But unfortunately, that treatment may not work for all the patients you diagnose. So this is mostly a generic diagnosis and empirical treatment. So this is what is called as the Oslerian paradigm, because it's a centuries old concept what we are following in the 21st century. And this Oslerian paradigm can work for a subset of patients, may not work for some, and can be dangerous for the rest. So this is because the current clinical scenario does not integrate the complete clinical and biological networks within a particular patient. We see only the gross clinical thing. So, and that's what precision medicine is about. And there are other challenges of the current healthcare systems, like meeting an individual needs in the Google World, the delivering the affordable healthcare, affordable high quality care, intersectoral coordination, aging populations. Why we are cancer capital? Because aging population, more diagnosis, and increasing rates of non-communicable diseases. So these are the challenges, and what are the prospects? We need to have someone who answers the population health in the early diagnosis and prevention and enhanced screening, as well as we need a personalized care for the individual patient. So we need to tackle the limits of the Oslerian paradigm. We need to have a medicine optimization, like what he told, managing the adverse drug reactions, identification of new targets and treatment approaches, and finally improving outcomes. So the current healthcare system is a lot of burden and expectations from this. So, and that's where the genomic revolution has come to the rescue. With the successful implementation of the Human Genome Project, and we have high throughput technologies with the other data source like biobank and big data, we have what is called as the functional genomics, that is integrating the biology genes of the patient with the phenotype of what he is manifesting. And as he said, there are a lot of tests we can do for genomics. I'm not going to details of this. So there are a lot of potentials. We can have a better diagnosis, better prognosis, optimized treatment, better disease monitoring. And the terminology is now changing into data-driven healthcare, value-based healthcare, and better individual-tailored healthcare. So omics, as madam said, we have omics, we have genomics, we have transcriptomics, we have proteomics, we have metabolomics, and in respiration we have exhale breathomics. So all these things are fitting into the death of the Oslerian paradigm. So in clinical practice, we have different scopes of genomic testing with regards to my profession. For example, prenatal screening can be used for primary ciliary dysplasia. I can diagnose antenatally the congenital diaphragmatic hernia, but more commonly we use for diagnostics and prognostics in inherited lung diseases. So, but as he said, I need to take it with a pinch of salt whatever report he gives. I cannot just apply to the patient. So there are a lot of interdependable parameters which I need to assess a genomic report. One, I need to consider the heritability of the particular disease, whether it is really an heritable disease, whether there is a penetrance, that is the exact phenotype, what is manifesting is related to the genotype, allelic heterogeneity, and allelic frequency. In lung diseases, there are some exclusive heritable diseases like cystic fibrosis in pediatric population as well, but we have common diseases like asthma and COPD which can also be heritable. So there are different patterns of tests for different diseases. For example, monogenic lung diseases like cystic fibrosis and alpha-1 antitrypsin, which are more heritable but less prevalent, we have linkage analysis. For less common diseases, more common diseases like asthma and COPD, which are less heritable, we have genome-wide association studies. I think depending on the clinical context, we apply this particular genomic testing. So very commonly, as I told, inherited lung diseases, we have the cystic fibrosis, alpha-1 antitrypsin deficiency, where they can help us in antenatal as well as the prenatal screening, as well as in certain adults who present with recurrent lung infections. What is more importantly, what I expect from the 30M people is that in lung cancer, we have a lot of things to offer from genomics. When I diagnose a lung cancer patient, I take a tissue biopsy, I take good for histopathological analysis, and just says whether it is small cell lung cancer or non-small lung cancer. And we have a standard treatment protocol, but that does not fit in for every patient. So what is the genomics has to offer is there is n number of mutations available, especially for non-small cell carcinoma. The most common are the EGFR mutations and the KRAS mutations. And if you tell us my patient is having this EGFR, I can put him on these specific drugs which have changed the outcome of these lung cancer patients, improving the survival of up to 3 to 5 years. It has been well proved in landmark studies. So I think this is one expectation from the respiratory physician to the team. And non-inherited lung diseases, bronchial asthma, yes, research purposes, I can tell my patient whether it is going to run for his children or her children. And for COPD as well, yes, these are a lot of epigenetic modulators available like smoking and pollution. But yes, a genetic backup will always help me in giving a replacement therapy for a patient with alpha-1 antitrypsin COPD. We should not forget respiratory infections. Tuberculosis. Tuberculosis is one where genomics is need of the hour. If you tell me my TB patient is harboring drug-resistant TB, using your old genome sequencing testing, I can straight away start this patient on MDR TB and can change the outcome of these patients. And this is what the National Health Program also is looking at. Standard genomic sequencing to tell the patient right away that whether he's having drug-sensitive TB or drug-resistant TB. There are a lot of drawbacks with the conventional technologies because I need to wait at least 3 months to know whether my patient is having drug-resistant TB or not. But with whole genomic sequencing, within a week you can let me know about the drug susceptibility status. So this is the South Indian data from Manipal where there's drug resistance has been, genes have been identified, and these results have been concordant with the conventional culture technique, almost 100%. So that is the beauty of the whole genome sequencing in infections. Never forget, COVID has proved the role of genomics in humans. And we have what is called as the INSAGOG. And if we have a good association with this genomic testing, we can be part of this INSAGOG platform as well. And all of us know that the current COVID variant which is prevalent across the country and across the globe is the JN1 variant. And this has been convincingly proved by the genomic testing. But it is a lesser variant than the conventional Omicron variant. So to conclude, genomics in respiratory medicine can help me to understand the biological basis of my disease. Whether it is asthma, COPD, there is a genetic component. Predict the disease susceptibility before my symptoms. Interventions targeted to disease biology. For example, in lung cancer, if you tell me my patient is having EGFR mutation, or if you tell my asthma patient is having a genetic marker which will not be responding to inhalation corticosteroids, I need to start him on biological agents. And pharmacotherapy, of course. Individualized prevention, yes, you can tell me whether my treatment will not fit into this patient. I can individually size my treatment. Thank you, and we expect a lot from this 30M team for further discussions. Thank you.
Ladies and gentlemen, this talk brings us to the conclusion of the session. I can assure Dr. Pranivale will meet most expectations from the clinical side because challenges are sugary. Okay. I'll tell you one information before you all leave. Genomic testing facility is located on the second floor of this college block. And my office is there. I run an open office. Any of you can stop by to know any information related to, and I'll buy you a cup of coffee. That's the deal. So if you like to have a cup of coffee, you can come to my office, but the payback is genetic testing. Okay? And I can educate you, and I can certify you in due course if you participate. With that little note, thank all the speakers, thank the Dean, Director of Hospital Services, Dean Academics, TM Genomics, and all of you for participating in today's first sensitization refresher program. There will be more. I will be communicating via WhatsApp with you. Please accept. Okay, please accept and learn. Save all the notes, save all the certificates, and wish you all good luck. Tea is available for any of you who feel